Okay, today we're focusing on a different topic that is often overlooked until it kind of becomes urgent: mobility, strength, balance, and fall prevention. So I'm joined by Nikki Carrington, a specialist in geriatric physical therapy, someone who has worked directly with older adults to help maintain independence and prevent injury. So good evening, Nikki. Thank you for joining us.
Hello, thanks for having me.
So how about we start with your background, Nikki? What led you into physical therapy and specifically geriatric physical therapy?
Um, growing up, I was always into sports. I wanted to be more into sports medicine. I ended up graduating with a bachelor's degree in exercise science, and I did my master's, which we specialize in cardiac rehab. I always thought I wanted to work with athletes, but then started to, find out that that wasn't really a field that was easy to get into. So I started working at a gym in Georgetown, and we mainly saw older adults, and I just really started to grow and learn more in that population. So I worked in that field as an exercise physiologist for about 15 years. And then I decided to go back and do my doctorate in physical therapy. I was a physical therapy major to start my undergrad degree, and I just didn't, get into the program. So I went back to school, finished my degree in physical therapy, and ever since then, just growing with older adults.
Okay. So let me ask you this, based on your experience, what are some of the common physical challenges you see with older adults?
I would say with older adults, the most common, of course, is, immobility with walking, ambulating. Um, they lose a lot of strength. Balance becomes, it is, statistical and scientific that our bodies, as we begin to age, we lose, more and more stability. And we have difficulty, specifically starting, I think, after the age of 35, we start to lose our balance every year. I think it's a challenge for older adults in that they wish to remain independent as long as possible. So they're not always, very honest with themselves on what their limitations are.
Yeah. So it seems like, just from my experience with my family, like some small mobility issues can turn into larger ones. What usually happens first? Is it like weakness, imbalance, or is it or it could be anything?
I think it's probably a combination of both. I mean, they're going to lose muscle mass and strength, definitely. They're losing their balance. Balance and muscle and strengthening are related, but they're not necessarily a result one of the other. So in combination of losing that, the worst thing that you want for an adult is to fall. You do not want an older adult, I should say. You don't want them to fall because once they break a bone, a hip, or something of that nature, usually you start to see that their mobility will decrease and their mortality rate will increase.
Okay. Kind of the theme of care without crisis is trying to prevent hurried decisions. So, I guess I'm asking how significant are falls in triggering hospitalizations and sudden care transitions. So, it can happen quickly. But it seems like what you're saying, falls are they generally the more common reason for hospitalizations, or it could be a number of things?
Definitely. Falls is one of the number one causes of loss of mobility and what brings older adults to the hospital.
Okay.
And it's a leading cause, evidently in death as well,
Wow.
depending on the severity of the fall, and it's not just about breaking bones. They can hit their head, they can get a bleed, a contusion, things, that they don't easily recover from.
Are there early signs that families might miss or things that they can see in advance?
Yeah, you start seeing your older adult, your loved one holding on to things when they're walking, always needing to, put their hands out to hold the wall or trying to grab onto you, um, dragging their feet and difficulty taking a really long time to go up and down the steps. Those are big signs, and older adults are the most they're the most they deny the most. I can walk, I'm fine. And you're seeing like the whole time they're holding onto a wall or the couch, the counters as they walk around. So also, I know you haven't asked this, but just to say, making sure that pathways throughout the house is cleared, carpets, rugs, all of those things are, if they're not securely down, things that they can cause them to trip. Because that's another thing is that once they start having difficulty balancing and walking, they don't like to pick their feet up. And what do I mean? They're dragging their feet instead of picking them up because they're afraid to let their foot leave the floor. And if they have things in the way, they're walking on carpet, that is a sure way that they're going to trip at some point and fall.
Yeah, I think, I speak with my family in particular. There were a few falls that we kind of became aware of just in conversation, but, my dad would just deny it. On
Mm-hmm.
denial of it. The thing
Yeah,
fall, I just tripped or, but
right.
it came to my attention they had a few scars on his body.
Mm-hmm.
Someone pointed out to me when I had to have a conversation with him, but he just wouldn't own it. So,
Right,
he kind of answered my question about what does physical decline look like. I think that
right,
it is what it looks like because sometimes, they hide it, and I get it. I get it.
right.
You
And
probably
you know what? We all trip. People trip. That's not necessarily an aging thing. The problem is their reaction time is slower. So they don't have the ability, like when they were younger, to stop the fall.
right.
The other thing they put their hands out, then they break their wrists,
Right.
and
Yeah.
so they can't react where they are reflexes that our body has in place that when we're moving in a specific direction, our body will react in order to counter it, right? And
Right.
that's, I mean, you probably, if you think back to times that you've tripped, you think of certain movements that you made. Maybe you didn't even need to catch yourself with your hands, but the way you stepped out, you were able to stop yourself from falling. Their body is not going to react as quickly. And sometimes because of weakness, they don't even have the physical ability to make that move in order to catch themselves. So,
That kind of brings in a whole nother conversation we'll get into another time about how do you, when you're speaking with seniors who aren't willing to they're not ready to own it yet.
mhm.
They're kind of in denial. How do you persuade them or maintaining their dignity to kind of, get some help or even physical therapy? So it leads me to another question. If the family wanted to prevent that sort of a crisis, when should they consider involving a physical therapist?
Anytime you start seeing, your loved one is having difficulty getting in and out of a chair, getting in and out of the shower, even getting in and out of bed, that they don't even have the strength to stand up without support or help. That you definitely know that they are starting to lose a lot of strength, which means more than likely when they're on their feet, they're not going to be able to balance that well. You see any difficulty with walking, a lot of tripping, their gait is odd. Like I said, a lot of grabbing onto the walls, grabbing onto you. Those are indicators that they don't feel that stable. I think that typically, even if you have a conversation with your loved one, it's usually best to start trying to have a conversation with the doctor. If you can go to the doctor's appointment with them and engage the doctor can help to give it to them a little more clinically. They tend to believe the doctor more than you because they always look at us as family members as trying to control them. Because I told you the number one thing in the aging population is they want to maintain their independence. And so it's trying to find a way, not just necessarily dignified, but for them to buy in. You want them to buy into it.
Okay.
So, just starting with small things like that, letting the therapist work with them, giving them the assistive device that they need, whether it's a cane, a walker, a rollator, whatever. And then also working on balance techniques, strengthening. And sometimes you can get, ergonomic people to come into the home, look around, see how the rugs are set up, find any clutter, lots of steps, what's easier for them to get in and out of bathtub, on and off the toilet, they help you set your home up so that they can live more
So would
comfortable.
that be considered like a preventive physical therapy? Or is that like a
Usually it's an occupational therapist.
okay?
So if you are able to get like home support, sometimes if a patient cannot get out of the house, that means they're home, but they really don't have the ability to get to physical therapy or occupational therapy or speech in an outpatient setting, then they can get home therapy. The therapist will come in and look at their home, and
Okay.
physical therapists do it, but you find more occupational therapists because occupational therapists help patients with activities of daily living. That's their goal.
So you're mentioning simple steps that families can take at home to reduce fall risk, like carpeting and kind of wider stairwells. Are there other things you can think of that might help?
Oh, definitely good lighting.
Okay.
Lighting is a big one. Even night lights, because that happens a lot at night. They get up, they think that they can do what, we were doing, or we even think that at 30, you can go to the bathroom without turning the light on. I mean, you've been in this house long enough, you know where everything is, but they can't see. They don't see, that the rug is rolled up, or they forgot, right, that there's a little step right there that they needed to step down, and so just making sure that the lighting is good in the house. If they're frequently going to the bathroom, the path is clear, the bathroom is close enough, so they can go, even if you have to get a bedside commode because they cannot get to the bathroom, also working on like things like trying to make sure they go to the bathroom before they go to bed. They're not drinking as much right before they go to bed so that it can reduce the amount of times that they have to get up and walk to the bathroom. If it's possible to get them a bedroom on the first floor so they don't have to go up and down the steps. Even if they get to a place where they need a lift. Now, those are the types of things we don't always like encourage lifts and things of that nature right away because we don't want them to completely lose their mobility. We want them to still be able to walk up and down the steps, but also techniques like, okay, you're going to go to work. Only thing that is upstairs are the bedrooms and bathrooms. So once they come downstairs, like they're downstairs,
Okay.
they're not up and down and up and down. They're bringing everything they need so that they can be set up downstairs, and they don't have to take the steps as often throughout the day. Making sure that things are close enough. They don't have to climb on chairs, reaching is also difficult because and this can get a little complicated. I don't want to get too technical, but so in order for us to maintain our balance, we have to have stability within what's called our center of mass, right? And so when you say your center of gravity. So if I'm standing, on my two legs, just standing straight up, my center of mass is somewhere around a little bit under my belly button in my belly like that. So once I start reaching out of my center of mass, I will put myself in a risk that I'm going to need to be able to know how to balance. So if I'm standing and I'm reaching for something that's on the counter, but it's outside of my center of mass, I'm
Okay.
going to fall if I don't know how to step forward and catch myself. And so that we find that with a lot of older adults, we have to keep telling them, walk right up to it. Do not reach, don't stand back here and bend down and try to get into the dresser. Walk up to it. Those types of things that, they need cues, a lot of
Mhm.
cues to make sure that they're using proper techniques. And also just a reminder, I mean, we are all going to go through the fact that it's hard to believe, like, oh, I need help. Like, maybe you need to sit down and put your pants on.
Very true. Look, speaking to me right now. Uh, let's talk a little bit about strength training and balance work for older adults. Is it ever too late for strength training or for them to start doing some of the things to strengthen their core or to get stronger all over the body for that matter?
No, it's never too late. I mean, we can always increase our strength. How much strength is matters and how they do it, but it's never too late. I mean, it's important. And sometimes, and that's why, they have in the community centers, the YMCA and all these types, some of these gyms have what they call the silver sneakers. Those are things that people who are trained to work with more geriatric senior citizens will do exercises that pertain more to them, and for maintenance programs.
Well, let's talk a little bit about the emotional side of mobility. We've spoken of this a little bit already, but what happens emotionally when seniors begin losing mobility or independence? Can you talk about that a little bit?
Yeah, definitely. They get depressed. I mean, it's depressing to start to learn that you are no longer able to do the things that you need to do, and then they need to ask for help. And sometimes, not everybody has people that can help them.
Hmm.
So it makes it difficult. And those people, they try to maintain their independence as long as possible. And they try, and sometimes they cause themselves to get hurt because they're doing things that really they can't anymore. But they don't have the assistance. And so, I mean, it kind of goes back to what I said earlier. Once people start to lose their mobility, the rate of mortality begins to increase in them. So we see it all the time. People break their hip, they're no longer mobile, they don't want to walk, the hip was replaced, but it's painful, or it's stiff, it's weaker, they don't go through what they need to, they can't walk anymore, and they don't survive too long.
Yeah, I think families are trying to find ways to encourage independence while still ensuring safety. It's a balance you kind of have to strike where you want to let them still be independent, but you kind of got to keep your eyes on them and kind of
Mhm.
for some of the things you're talking about. And when, I guess, maybe another question is when does declining mobility kind of become a signal but you may need more support? I mean, is there a trigger for families when they know that, you know what, maybe it's time now that, we need to take another step? I mean, obviously a fall might be that, but I think a fall might be too late, if you get to that point.
Well, when you see that they're struggling to do the normal activities of daily living, being able to shower themselves, go to the bathroom, like I said, walk around, clean the house, you'll see those signs. They're not taking the trash out. They have 3 weeks worth of trash sitting right at the back door or in the house itself. They're not bathing. You're living with a parent who was taking 2, 3 baths a day. Now all of a sudden, it's 3, 4 days and they haven't bathe, or you see laundry is piling up. The laundry room is in the basement and they haven't been able to go down there to do it. Dishes, they're not, when you start noticing those types of things, they may not tell you, they may have a ton of excuses, but usually those are kind of telltale signs that they are struggling to cook. If you go pick your family member up and take them to the grocery store and you see they're leaning on the they're leaning on the cart is their walker, and they're struggling to get things off the shelf and to manage themselves, and it just, to me, it's paying attention, being present, and just observing how they function in the house. My mom is a senior. She's independent. She lives by herself. But when I go to visit her, I watch her. I watch to see how she moves, how long it takes her to, do certain things. There are certain things we ask her to not do for herself, like, for instance, taking the vacuum up and down the steps or big items. That's another thing talking to her about. Like, you can't take everything up the steps at one time. You're gonna have a free hand so you can hold on.
Yeah.
And just watching those things. My mom also was a nurse. So for me, my biggest thing to watch is she stops being able to take her medication on time. I know something's not right.
I think I walked into my mother at 85 years old on a ladder. I'm like, what are you
Exactly.
what are you doing changing a light bulb? But I mean, she's done it her whole life, and I'm like, Mom, we gotta talk. You cannot be on a ladder home by yourself. That's not gonna.
No. Yeah, those are things too. We asked her, like she was trying to take wallpaper down and she wanted us to come, when you're here, I'm gonna take it down. But just looking at her, I was like, that is not safe. Like, get down. Let me do it.
I get it. Let's pivot a little bit. I want to
Mhm.
talk about discharge planning and
Mhm.
transitions.
Yeah.
So, from your perspective,
Mhm.
I know you have experience in hospitals.
Mhm.
What commonly goes wrong after discharge planning?
So, discharge planning can be complicated, specifically with a person who lives by themselves. So, the therapist will come in to decide whether or not the patient can go back home. And usually, depending on the services they're getting in the hospital, occupational therapy, physical therapy, or speech, and they'll collaborate. Speech not only deals with swallowing and talking, but speech also deals with the cognitive function, right? So you got an elderly person, let's just say we have a patient came in, had a stroke, and their residual deficits are very mild. They're still able to walk and they're talking fine. Well, maybe there's a little weakness, but it's not horrible. Um, the speech therapist will be the ones to come in and decide, is this person cognitively fit to go home? In other words, if I ask you, how are you today? To say fine, and how, are you in a hospital? Yes. What's your name? Oh, my name is Nikki. But if I say, hey, can you show me where the apple is? And you pick up a pencil,
Right.
or, if I'm asking you yes or no questions, you can answer that. But are you able to go home? Like, do you know the difference between a book and the remote control? Then this is a person, they might be fine physically, but they can't go home. So I just wanted to put that little nugget in there about speech and the importance of, cognitive, because you might find that there are no physical deficits. They're fine. And then you start to see, like, why is she putting the can of beans in the refrigerator? It's unopened, and things of that nature. So um, we make the plan and we say, hey, I don't think this person could go home, or I think this person can go home. If they're too weak, let's say I go to walk with you, you can walk, but every 5 feet you need to rest and stop. Well, 9 times out of 10, in your house, your bathroom is going to be at least 20 feet away, if not more, right? If you have to stop and rest every 5 feet, well, how are you going to make it to the bathroom when you have to go? So those are things that we look at. The occupational therapist is looking to see, do you need help to dress, to get yourself, together, not only with upper body strengthening, but also are you struggling to wash your face and brush your teeth and take care of yourself? If people, usually we like to say, hey, this person should go to a rehab. If it's an acute stroke, they're old enough, young enough, they can handle 3 hours of therapy, we'll send them to an acute rehab. If they can't handle that much therapy, then we'll send them to a subacute rehab. Their goal then would be to work on strengthening so that they can at least get them as close to being safe as possible. Sometimes you get families that say, hey, I don't want, my parent to go to a rehab. I just want them to come home. And, if they push hard enough, it's not jail. I mean, they get to make their own decisions. So if they refuse, they can go home, and they usually can get home health or some sort of home PT or OT. Now, in the case that we have people, and we have it a lot, who live by themselves and they don't have anybody at home, we typically, they push, push, push. We try as much as we can to keep them in the hospital until they can, be able to do what they need to do. However, as you know, insurance is difficult. So if an insurance company says, hey, in 4 days, this patient should be gone, they're not going to pay anymore after 4 days. So they can stay for 2 weeks, but they're not paying.
That's the issue. I think a lot of families aren't prepared, I think, for the level of assistance needed. Like,
Yeah.
I don't know if patients are ever sent home too soon. I guess there can be instances of that where patients may go home too soon. I don't know, but I guess maybe the question is what questions should families ask before agreeing to
Yeah.
be discharged home?
No, so that was the thing I was going to tell you is that it's not they get sent home. Listen, one and they're in the hospital, it's acute care hospital. Once they're medically cleared, blood pressure is stabilized, whatever, they can they it's time for them to go, you know. So they may not be strong enough, but it's not the goal of the therapist in an acute care hospital to get them that strong. It's to get them to the next level, the next setting. So we may say they need rehab. If they refuse rehab and they go home, let's say a family says, hey, we really want our parent home. They get home and they realize this is a lot. Like, I got to go to work. I cannot sit here with her all day. Sometimes they just bring them back to the ED and then we get them placement, you know. Typically placement has to come, you know, from the hospital. They usually get discharged to a rehab or home. They don't go from home to a rehab, you know.
Having two parents in their 90s, I think I've seen, even we've been guilty of it. I think there's a misperception of what hospitals do. Hospitals, once they get you well, um, you're going home. You're going
Yeah.
somewhere.
Yeah.
Unfortunately, I think a lot of families aren't prepared for that.
Mm-hmm.
They feel like, the hospital's doing them an injustice or the insurance companies is. But the fact of the matter is, I mean, they've been stabilized to your point. The hospital's
Mm-hmm.
done their job. Now it's time to hand it off. And I think
Mm-hmm.
sometimes families don't really understand what that cutoff is. I know we didn't. And we had
Mm-hmm.
quickly that there is a cutoff, and the hospital says, okay, we've done our part. Now
Mm-hmm.
it's time to move on. So, which I think that's important what you said. So, um, another question I'm going to ask is, what role does physical therapy play in preventing readmission? Because I hear a lot of stories about people coming out of the hospital and having to go back.
Mm-hmm.
So can you speak to that a little bit in your
So
experience?
physical therapy in an acute care hospital, their role is to make sure that so where they're getting discharged, that's what we call their disposition, that the disposition is correct. Okay. 9 times out of 10, you don't get the readmission if the patient goes to the recommended facilities. However, you will get readmissions for patients who want to go home, or unfortunately, there are some patients who have no insurance, they can't get acceptance. You also, you know, these places get to pick and choose who they want. If you're certain things in your background, they decide if they want to pick them up. So when we can't get placement, they decide to get home, then you will get more of that readmission. So I think I've noticed in my career the most we get a high incidence of readmissions because people don't want to go to the recommended facilities. They want to come home. And I understand that, you know. And either they fall or they realize they can't handle it, families as well as the patients. So I will say this, typically basically in a hospital, if the recommendation is for the patient to go to a facility and then they refuse and they come back, they can be charged because 9 times out of 10, insurance is not going to pay the hospital to readmit a patient in less than 30 days for the same diagnosis. Also, it's a ding to the hospital. The hospital can get a fine for that.
That's good to know.
Mhm.
Okay. The last few minutes, I'm going to see how much more you can help some families. There's a lot of good stuff you're giving. I want to ask you if you could give a family one piece of advice about aging and mobility before a crisis occurred, what would it be?
I guess I would say start now. You know, prevention starts right now. You don't have to wait for signs. That's a little ridiculous. You know, you start now, getting them signed up, water aerobics, some sort of exercise class. You know, you're working on the balance and things of that nature, and start planning. Start planning. I mean, it's inevitable. 9 times out of 10, the expectation is that your loved one will age and they will need help and they will need care. So there should be a plan, you know, even, and I don't just even mean, oh, for death. I mean, for what if they fall, but they live for another 6 to 10 years? What's the plan? So I think that is important. And you know how your loved one is. If you are, some people have 68-year-old loved ones who already are uh, not mobile, aging, and in bad shape. You know, Some people have 89-year-old family members who are still driving, still walking, still living on their own, cooking and taking care of themselves. But make sure that you have a plan, have a conversation with them, get the buy-in before you get to the point where you have to start making choices.
Yeah, I think like when you start noticing signs of decline and you're not sure what to do, I mean, what do you tell? I mean, I guess how do you recommend adult children begin having that conversation? Maybe how do you begin having that conversation with mom, dad, aunts, uncles about, hey, I see something. Would you consider, I guess maybe you recommend water aerobics or sign them up for a class. Do you have any recommendations?
Yeah, I think that, I think the biggest thing for a lot of people, nobody wants to fall, and safety is like number one. So, using those code words like, hey, I noticed that you don't always seem like you're that safe when you're walking and moving around. I'm worried that you may fall. No, no, I'm fine. I don't know. And, you just bring it to their attention like, hey, can you walk around the house without holding on to the wall? Or you notice that trip, and start just bringing it to their attention. They know, they also know,
Okay.
and I think from more from a standpoint of saying like, hey, I want you to get stronger, or I want you to, work on your balance. I think it's just it's important for them to know, like, I want you to be safe. I want you to, be able to maintain your independence and do what you need to do safely. And so let's get started on some stuff so that you can continue to live by yourself or do what you do every day. So,
Well, Nikki, I want to close this call by just thanking you. You brought pretty heavy hitting information tonight. So it was a short conversation, but you dropped a lot of knowledge. So I think conversations like this will really help families replace fear and assumptions with some clarity. So
yeah,
I will say anyone watching this, if you want some more guidance or practical tools, you can check out our website and there are plenty of other resources out there. So Nikki, once again, thank you for your time this evening. And
you're welcome.
I will be in touch. You've been great.
Okay, thanks for having me.
Thank you for having me. Have a good day.
Okay, bye
Bye-bye.
bye.